Thank you for joining iMeet. When you hear the tone, you will be the 18th person to join the meeting. Meeting is now being recorded.
I would like to welcome everyone to the AABIP monthly webinar series. On behalf of my co-moderator and organizer, Ara Christian, and myself, we would like to thank our speaker for joining us today. But before we start, we would like to review some basic housekeeping items. Number one is we would like to alert everyone in the audience that the webinar will be recorded and available for future viewing on the AABIP website. The second thing that we request is that all audience members mute their telephone to try to minimize their background noise. That will improve the recording quality of our session. During the course of the session, if you have any questions for our speaker, we encourage you to use the chat box function. The chat box is located on the bottom left-hand part of your screen. And during the course of the talk, we will monitor the questions. We've asked Dr. Criner if during the course of his talk he chooses to answer your questions during the flow of his talk, that is fine, versus we will keep track of them and moderate them at the end. Please also note that the AABIP does not specifically endorse any specific technologies or products, and the contents of the presentation are the opinions of the speaker. So without any further delay, I am very pleased to invite our speaker today, Dr. Gerard Criner from Temple University. He will be speaking to us on bronchoscopic lung volume reduction. And for anybody who is familiar with the field of COPD, they're undoubtedly aware of all of the expertise and involvement that Dr. Criner has had both in the broad research field of COPD, as well as all the new and up-and-coming technologies with regards to bronchoscopic lung volume reduction. So thank you, Dr. Criner, for joining us today, and I'll turn the floor over to you.
Well, David and Ara, thanks very much for allowing me to speak to the group tonight. And I know for some of us it's later in the evening, so I'll probably speak for about 30, 35 minutes. I'll try to answer the questions as I go along if I can see them, and I'll leave ample time for questions at the end. These are my disclosures. So what's the importance of this? Well, all of us that treat patients know that hyperinflation is devastating in patients with chronic obstructive pulmonary disease, but it's most important in those patients who have emphysema. And the reason for that is the product of increased lung compliance and increased airways resistance is only found in patients with emphysema. And the product of that increases to a prolonged expiratory time constant that leads to static hyperinflation, and when a patient moves and exercises, to co-development of dynamic hyperinflation. The degree of hyperinflation that patients have correlates better than any other physiologic measurement, including FEV1, the patient's increased sense of breathlessness, to their decreased exercise performance, to their reduced quality of life. And it's the reason why patients develop respiratory failure and require mechanical ventilation in ICU. It's been shown by several studies to be associated with increase in mortality. So why is it so devastating? As many of you are aware, it impairs lung mechanics in portions of the lung with less emphysema. It has adverse effects on respiratory muscle mechanics and chest wall mechanics, as shown on this plain radiograph of one of our patients that we treated, where the curvature of the diaphragm is markedly reduced, the area of apposition of the costal diaphragm with the rib cage is markedly reduced, and a radius of curvature is reduced. And more importantly, or as importantly over the last decade or so, it's shown a direct correlation between the percentage of emphysema and the degree of hyperinflation with decrease in cardiac chamber filling. So cardiac embarrassment is also a consequence of severe hyperinflation. So of all the things that we can mark in patients with emphysema and COPD, hyperinflation is a key parameter of patients that will do worse. So if we look at lung volume reduction surgery, a potent treatment of hyperinflation, can we show the opposite? That by targeting hyperinflation, can we improve patients' outcome? And the answer to that from the National Emphysema Treatment Trial is that yes, we can. In some patients with upper lobe predominant disease and low exercise performance, low exercise post-rehab, that's a marker for ventilatory limitation of exercise. Patients that receive lung volume reduction surgery compared to optimized medical care, they have an improvement in survival. There's an improvement in lung function, exercise performance, and quality of life. There's about a 23% reduction in the development of exacerbations that correlates with the improvement in lung function overall. But as we know, surgery can have some negative consequences. It's associated with mortality in patients that are prime group for surgery, upper lobe predominant patients. There's approximately a 4.3% mortality at 90 days compared to optimized medical treatment. There's about a 50% cardiopulmonary morbidity related to either pneumonia, COPD exacerbations, or increase in supraventricular tachyarrhythmia. And we know even in carefully selected patients, it doesn't help all patients, and overall it has limited access and can be costly. Cost of the intervention is about $180,000 per year in 2003 dollars. So it's not the least expensive or less morbid intervention. So that's why the field has moved towards consideration of bronchoscopic lung volume reduction that started in the late 90s, about 1997, 1998. And the several different therapies that have been developed all relate to three major pathophysiologic treatment lines. One is targeted lobe atelectasis. Endobronchial one-way valves is one way of achieving that, or self-activated coils is another way. Second group is targeted destruction and remodeling of emphysematous tissue by either biologic lung volume reduction with sclerosing agents or tissue adhesives that are infused to the airway, or vapor ablation, which is thermal heating of lung tissue that can cause transformation of emphysematous tissue to scarring and atelectatic tissue more slowly over time. And the third is just trying to bypass the abnormal airways that happens to decrease of tethering because of poorly compliant lung tissue by putting artificial conduits or airways in. Sphericals or stents that Peter Macklin showed in the late 80s by either an endobronchial route or transpleural by putting them externally. In some cases, even using modified external chest tubes. So these are the kind of studies or examples of things that have been looked at to achieve these bronchoscopic routes of lung reduction. The endobronchial valves that you can see are both FDA approved as now, and I'll spend the majority of my time talking about that. Lung coils, vapor ablation, and foam have been studied extensively. Lung coils are still undergoing evaluation in Europe right now as part of the Elevate trial. They have about 30% of the patients enrolled out of that 100-patient study. Vapor ablation is approved therapy in some parts of Europe right now, not approved in the U.S., but there's a current planned U.S. study that will be hopefully available in the next year or so. And then there's early phase trials using Aerosil that was used in the U.S. and the company closed and it was repurchased by another company. And that's early phase 2A trials that are being conducted in Europe. And the Excelled stents went by the wayside due to a negative study that was reported about a decade ago. So let me give you some background and really focus on endobronchial valve therapy because it's an FDA-approved therapy now, and it should be available to where you practice right now. So I wanted to spend the majority of my time talking about that. So what we learned from the VENT trial was instrumental in how we've conducted the larger trials that have been used to get approval from the FDA. The VENT trial was a multi-center randomized trial, 31 centers in the U.S. that was reported in 2010 that randomized patients 2-to-1 to optimized medical therapy plus Zephyr endobronchial valve versus optimized medical therapy alone. There was two co-primary endpoints in that study at 6 months. One was improvement in breathing mechanics by improvement in the FEV1. The second co-primary was a change in 6-minute walk distance. And there was additional efficacy endpoints, measurement by volumetric CT of a reduction in targeted lobe volume, improvement in St. George Respiratory Questionnaire, and an aggregate improvement of pulmonary and non-pulmonary parameters in the Bode Index. And then the primary safety endpoint was a major complication composite occurrence rate, which we'll talk a little bit about. So the pivotal primary endpoints are shown on this slide, that there was statistically significant improvements in FEV1 and statistically significant improvements in 6-minute walk distance compared to baseline in the group that received the Zephyr valve compared to optimized medical treatment. But when this went to panel, the therapy was not approved because although clinically statistically significant, the group mean changes were not considered to be clinically meaningful. What was noted was in about a third of the patient population, there were not only just statistically significant, but also clinically meaningful improvements in FEV1 and 6-minute walk distance. And the FDA said, go back and do a study that would focus on that patient group. That company went out of business, and Pulmonx later purchased the Zephyr valve. This looks at post-hoc analysis that we did in the VENT and EuroVent trial with looking at patients that had a clinically important improvement in FEV1 and associating that with what factors, which we thought were the four most important factors were complete fissure, target lobe, heterogeneity, and the fourth was proper valve placement. We took that away from this analysis because we couldn't predict that at baseline, but what we could use to predict baseline are these three variables: heterogeneity, target lobe that was chosen, upper lobe, lower lobe, left or right, and whether there was an intact fissure or not by QCT analysis. And what we found was the thing that really resounded was if there was a complete fissure present, these patients had almost a 4 times greater likelihood of improvement in FEV1. For heterogeneity in this analysis, we used a 15% difference between the targeted lobe for treatment compared to ipsilateral non-targeted lobe. Well, trying to predict by QCT is one method, but physiologic characterization to look for collateral ventilation is another method that was reported about 8 years ago. And this is using the Chartis apparatus, which is a endobronchial flow probe that's balloon tipped and placed through the bronchoscope through a 2-millimeter channel, and has a console that you can use to measure whether there's a decrement in flow with an increase in pressure in a spontaneously breathing individual, or just a decrease in flow in a patient that is on positive pressure ventilation. So this study by Danielle Goppelman that was published about 10 years ago shows an example of a high collateral resistance shown in the upper portion of the slide. Let me see if I can get this pointer to work. Shown here, where there's a decrement in flow shown in the green of expiratory flow over time with an increase of pressure that's measured at the tip of the probe, showing that there's an intact fissure in this case and no evidence of collateral ventilation. And in the bottom, showing a low collateral resistance or collateral ventilation lobe where there's continuous flow across the measured balloon-inflated targeted lobe and no change in pressure, no increase in pressure over time. So the top would be a lobe that you would treat and expect that you would have a good outcome because there's no evidence of collateral ventilation, and the bottom would be a lobe where you would not treat because of continued flow. So when you apply these principles to look at patients prospectively, which was done by Karen Klooster and Dirk-Jan Slibos in the Stelvio trial, you can find not only statistically significant, but clinically meaningful improvements in lung function and other parameters, such as 6-minute walk distance. And as you can see in this slide, this study was done in 68 patients, and the patients had endobronchial valve therapy compared to control. The patients, for the most part, exceeded the MCID for a change in FEV1 from baseline at 6 months with greater than 100 ml improvement. In this case, it was about 150 ml improvement in FEV1 in 6 months. Spirometry was also improved in a kind of like a similar magnitude. You can see a significant improvement in 6-minute walk distance above the MCID of 25 meters. It was almost double above that in this study. And if you look at whether it can be done, and it can be done in a multi-center trial, that study done in Denmark was done with highly skilled individuals, operators that were experienced in assessment of collateral ventilation by using the TARDIS, and also in selection of patients for endobronchial valve therapy. The Transform study was a multi-center European study that followed patients out to 6 months. You can see, again, that you can get clinically significant but also durable improvements in FEV1, 6-minute walk, reduction in residual volume, improvement in SGRQ by a decrease in the score, and improvement in the BOE by reducing it by less than 1. The slide here shows the EBD group is shown in the blue, the control group or standard of care is shown in the gold, and the differences between the two groups here is shown in the green. That leads us to the Liberate trial. The Liberate trial, and you can see what the Liberate stands for, was the first multi-center randomized controlled trial to look at the value of endobronchial valve therapy, again using the Zephyr valve, out to 12 months. And I'll tell you as we go along why this is important, why 12 months is important overall. It was a multi-center trial. It was international. Most of the sites were U.S., but there were some European sites also involved. There was 190 subjects that were enrolled into the trial, and you can see the measured variables, and I'll show you the baseline data as we go in. And the patients were all physiologically characterized for collateral flow by using the TARDIS system, as shown here. Patients had to have this as an entry criteria at the time of bronchoscopy. If they were collateral ventilation positive, they were excluded from the trial. If they were collateral ventilation negative, patients were enrolled into the study, and they were randomized 2-to-1 to control versus standard therapy. They also had to meet QCT parameters. Lost that slide for a minute. QCT parameters before the patients could move to bronchoscopy. They had to have a degree of destruction in the targeted lobe greater than 50%, and a degree of heterogeneity between the targeted lobe and the non-targeted lobe of 15%. So they met these QCT parameters first before they moved on to the bronchoscopy that further identified whether they are eligible to continue in the trial or not. So these are the baseline characteristics of patients that were enrolled in the Liberate trial. They're about 60 years of age. Their BMI was about 24. Their smoking history was extensive. They had about 50 pack years overall. The targeted lobe percent of emphysema was about 70%. The heterogeneity between the targeted lobe and the ipsilateral non-targeted lobe was about 25% overall. Diffusion capacity was in the low 30s, and the residual volume was about 225% on average overall. 6-minute walk distance was about 300 meters, and the SGRQ was in the mid-50s, and the CAT score, in the most part, was in the 20s. The MMRC was about 2.4 to 2.2, and the BODE was 5, with about 30% of the patient group prescribed continuous oxygen therapy. So this is a sick patient group of patients overall that were about gold 4 disease overall for the patients. This is the flow diagram, and there's just 2 important points I want to illustrate out of this. And I think this is important because you'll see this in clinical practice. The screen to enrolled ratio is about 4-to-1, and that's what we see in our clinical commercial program with BLVR overall, to select patients that are appropriate for having no evidence of collateral ventilation or fissure integrity, and having a pattern of emphysema on qualitative inspection that would be important. The other thing I wanted to tell you for the Liberate study is that one of the values of the Liberate study is they had good retention to patients to the primary outcome. 98 to 95% of the subjects had evaluable endpoints at 1 year. This shows that the data is pretty reliable in terms of what you can talk to your patients about what they can expect in 1 year follow-up. This is moving on to the primary outcome of Liberate. This is a percent of patients that had a change in FEV1 that was greater than or equal to 15% at 1 year. This endpoint is a little bit more robust than what's usually considered to be clinically meaningful endpoints, but to use a responder analysis, this was what was agreed to with the FDA before the study started. So at 12 months or greater than or equal to 15% improvement in FEV1, we're seeing about 47.7% of the group that received a Zephyr valve for endobronchial valve treatment for lobar occlusion, compared to 16.8% in the control group as shown here. I think 2 points are, you had a very good response in patients that had collateral ventilation negative with endobronchial valve treatment. But you can see a 16.8% improvement in patients just with usual therapy in patients that are enrolled into a clinical trial, which emphasizes the clinical trial effect of patients adhering to good medical therapy. They should expect an improvement also. And I think it's just supportive of the need to do randomized controlled trials, and that some of the medications that we give patients is effective not only to maximize their performance before therapy, but also to maximize their performance after the therapy that we give. These are some secondary endpoints shown on this slide. This is, to the left shows the change in FEV1 from baseline. It's about 100 mLs overall at 12 months compared to usual care, which was negligible. If we look at 6-minute walk distance, there's about a 18.6 meter improvement in FEV1 and a 39.9 meter difference compared to the interventional group with Zephyr valve compared to control therapy. And I think one of the points I like to illustrate is in FEV1 in the patient group with severe COPD, especially those with emphysema, declines over time. In the NET trial, we showed a 40-meter decline in FEV1, and in the ReNeu trial, the lung coil trial, we showed about a 29-meter decline in FEV1. So with optimized usual care, you'll usually see a decline in 6-minute walk distance in the group with maximal medical therapy overall. And then to the right, you can see the change in SGRQ. There's a 7.7 reduction in SGRQ with the Zephyr valve at 12 months compared to the control group. And you know that the clinically significant improvement in a reduction in SGRQ, which relates to an improvement, is at least 4 points. And then one of the reasons that Liberate is important, it's large and multi-center, but it's also one that followed patients out to 12 months. They could look at a peri-procedural period versus a longer-term period to separate out the complications and the benefits of the therapy. But as this slide shows, the durability of the response. And again, the color coding is similar to the Transform study. Then the bronchial valve Zephyr group is shown in blue, the control group is shown in gold, and the between group difference here is shown in green. And one can see this improvement in FEV1 that is durable over the period of time of follow-up at 12 months. It's related to a reduction in residual volume. It's determined to be consistent over the 12-month period of time. The improvement in quality of life shown by the St. George Respiratory Questionnaire. And you can see the delta difference shown in the green here continues to increase because of the deterioration in the 6-minute walk distance shown in the control and the stabilization and improvement in the FEV1 that's shown in the Zephyr valve treated group. So why does this happen? Well, I think this slide illustrates it better than not. It all revolves around volume reduction, which is what we're trying to signal and treat overall. That 84% of patients in the Liberate trial who were treated with the Zephyr valve had a clinically significant reduction in the targeted lobe volume. And that's shown here by a 350 ml improvement. And when you can see those kind of improvements in hyperinflation, sure this thing keeps bouncing around, you see across the board about 50 to 60% improvements in lung function shown by the FEV1, reduction in residual volume that complements this TLVR reduction, improvement in quality of life, walk, dyspnea reduction, and improvement in BOD. So it all revolves around the target, which is hyperinflation, and effectively decreasing the amount of air trapping that these patients have. The MCIDs are shown here on the bottom.
So Jerry, I apologize. The slides seem to be skipping around, and I'm not entirely sure why, but if you want, I can also try to help make sure that we are on the slide that you would like us to be on. So I can manually just move them forward. But as I mentioned, they're seemingly skipping a little bit. I apologize for that.
That's okay. So why don't you move to the one after this one, pneumothorax, and if it's better, David, I'll just tell you to advance it.
Sounds good. We'll try that and see how it goes.
Okay. So this looks at the most common unique therapy related to this bronchoscopic treatment, which is pneumothorax that develops post endobronchial valve treatment, and this is what we showed in the Liberate trial with using the Zephyr valve. And with endobronchial valve treatment in general, you'll find the peak of the pneumothorax that occurs happens within the first 72 hours after valve treatment. In most cases, it's about a 26 to 30% occurrence rate. 84% of these patients in the Liberate trial received chest tube for treatment. 16% did not. The reasons for that is if you reduce the lobe and lung more than you reduce the chest wall coming down to the lobe, then you're going to get an ex vacuo pneumothorax. That is a pneumothorax that's a space without a bronchopleural fistula. But in patients that have a large space that's suggested to place the chest tube, if there's an air leak, then obviously the chest tube will need to be in place. And I'll mention some things about the differences in pneumothoraces a little bit later on. But in any event, about 75% of the pneumothoraces happen within 3 days post-treatment, and on average about 80+% of them, 84%, at a chest tube place. You can also see that about 12.5% of those patients required an endobronchial valve to be removed to help to seal the leak by expanding the lung, and it's suggested, and you can see that in the supplement of our paper, that 1 or 2 valves will be removed at 12, 24, or 48 hours if the leak is severe overall. Next slide, Dave. This looks at the consequence of a pneumothorax on patient outcomes, and the patients who had a pneumothorax are shown here with endobronchial valve compared to those without a pneumothorax, looking at important outcomes such as change in FEV1, SGRQ, 6-minute walk overall. And as you can see, it's identical, that the patients who had a pneumothorax overall did not have a worse outcome in terms of any parameter. In fact, if you look at some studies that have been reported by Felix Herf and his group in Florida Clinic, that the patients that had a pneumothorax tended to have a better outcome in some of their series by having a greater reduction in volume that was hypothesized to create a greater risk of pneumothorax. We did not find that in the Liberate study, and whether that's related to multi-center nature versus a unicenter nature, it's not clear. But in any event, if they had a pneumothorax, they had a similarly good outcome. Next slide. So one of the important things, like I mentioned before in Liberate, it was long, is it a year? And we a priori defined with the FDA when we designed the study that we did it this way to look at a peri-procedural period, because as you know, with any kind of intervention with patients that are sick, like this patient group, that the likelihood of the procedure itself causing an exacerbation or respiratory failure is higher than other interventions that we do. So we wanted to have that period within the first 45 days after the procedure, and then have a longer period of time, a convalescence period that would be day 46 to day 365. So we could look at some of these complications of the procedure that might spike, like you see with surgery, and whether they would involute, like we saw with lung volume reduction surgery, that after post-effective treatment, that perhaps the exacerbation risk or respiratory failure risk would be lower in patients that received septal valve treatment. So as you can see, next slide, Dave, that the exacerbation, the pneumothorax rate obviously is higher in a group that received endobronchial valve treatment. The first 45 days, it was 26.6% compared to none in the standard of care. You can also see that the exacerbation rate was 7.8% compared to 4.8%. But if you look at after 45 days, the exacerbation rate is actually lower. These are adjudicated exacerbations by a clinical review committee. You can see it was about 7% less in the groups that received the endobronchial valve compared to standard of care, which didn't meet statistically significant change, but was close to it. And next, Dave. The respiratory failure was less. That as you follow these patients out over time, respiratory failure that was higher, 2 patients had it in 45 days after Zephyr valve treatment, that reversed when we followed these patients over a longer period of time. And actually, the mortality that wasn't statistically significant different at any time tended to be reversed as we followed the patients out farther. So further follow-up, if the trial was longer and if the trial was bigger, we expected some of these features to mimic what we showed with lung volume reduction surgery in a much larger net trial overall, signaling that we had effective treatment of hyperinflation, mimicking hopefully what we could see with surgical treatment. Next slide, David. So these data that I showed you are in patients with heterogeneous disease, defined by greater than 15% difference, and overall it was 25% different in the Liberate trial when you look at the data. But this is a study that was done by Arshan Valapur and other European colleagues and reported in the Blue Journal about a year and a half ago, where they looked at patients with homogeneous disease, and they enrolled 93 patients, again, 2-to-1 Zephyr valve treatment compared to standard of care. And they treated them with lobar occlusion, standard way that we just talked about, with isolating lobes of the lung by collateral ventilation negative. The only other feature that they did, which I'm not going to discuss further for sake of time, they also did a perfusion study and treated the area of the lung, because this was homogeneous disease, that was less perfused by 20%. Next slide. And what they found also was they found a 17% difference in improvement of FEV1 at 3 months compared to those who received standard of care. Next slide. And they showed durability of these responses at 6 months in terms of 6-minute walk, change in FEV1, reduction in breathlessness measured by the MMRC, improvement in quality of life, and a durable reduction of residual volume by about 500 mLs overall. So these data corroborated what's found in patients with heterogeneous disease, that homogeneous patients may also benefit compared to just continuing them on maximum medical care. Next slide. So let me talk a little bit about now this spiration valve system, which is the other approved endobronchial valve. And this is some data from the REACH trial, which was published by Lee in Respiration in 2018. And this is a multi-center prospective randomized controlled trial that was done in China. It was a 2-to-1 randomization. The endpoint was at 3 months, and the primary endpoint was FEV1 compared to baseline, and the secondary endpoints, as are shown, targeted lung volume reduction, SGRQ, and 6-minute walk distance. In this study, the way the design was, the screen to enrolled ratio was a little bit lower. It was 3-to-1 compared to 4-to-1 in the Liberate study. I think it might have been just the way the patients were referred to the centers. And next slide, David. And you can see there was good retention of patients of primary outcome, again, in this study, about 90% overall. Next slide. These are some of the patient demographics and looking at the lobes that were treated and the valve size that were used. Comparable to the prior study that we talked about, these patients were in the mid-60s. They were severely obstructed. FEV1 was about 28% of predicted. They were also significantly air-trapped. The residual volume was about 260% of predicted. Emphysema was significant. It was about 62% overall. And there was about 28% heterogeneity between the targeted lobe for treatment and the ipsilateral non-targeted lobe. Quality of life was impaired. The FEV1, the SGRQ was about mid-50s, and the CAT score was in the 20s, and the MMRC was about 2 3/4 overall, with a 6-minute walk was in the low 300s. You can see when they treated the patients, in most cases, it's a upper lobe or a left-sided treatment. The upper lobes were treated in about 70% of the patients, and about 80% was left-sided treatment. It's however you look at it. And if you look at the sizes of the valves that were used for the three sizes that they used in this study, about 42% were 7 millimeter, 36 were 6 millimeter, and the minority, 22%, were 5 millimeter valves. The overall number of valves that they used in this study was about 5.2 per procedure. In the Liberate study, it was about 4.3 valves overall. Next slide. And this just looks at some of the primary outcomes of the study. To the left, you can see that the absolute change in FEV1 at the endpoint of the study was about 100 mLs overall. At 1 month, it was, at 3 months, it was about 100 mLs overall, and the difference was about 100 mLs overall at 6 months. If you look at a responder analysis, those patients that had greater than or equal to 15% improvement at 3 months was 48%, and the ones that received the SVS valve system compared to 13% in the usual care. You can see this change in 6-minute walk distance was statistically significant at 6 months, was favoring the intervention group compared to control, with again the SGRQ difference being about 9 points lower in the group at 6 months in the patients that received the SVS system compared to standard of care. Next slide, David. This looks at the complication rate. Device-related is shown on the top, and then procedure-related is shown in the middle, and device and procedure-related are shown below that, and then unrelated below that overall. And next slide, Dave. As you can see that the pneumothorax rate here is 6.6%, this device and procedure-related, which is somewhat lower than what I quoted to you in the Liberate study. The reasons for this aren't known. There's a couple reasons that were given by the investigators in the discussion of the paper. One was the percent of emphysema overall is slightly lower than other studies, and perhaps that contributed to a lower rate of pneumothorax. This is the first study that they did within the bronchial valve treatment with these investigators in a multi-center fashion, and perhaps they were less familiar with that. Perhaps that might have accounted for why their pneumothorax rate is lower than what would be expected overall. But the real reasons why that exists isn't really clear from at this time. Next slide. So that leads us to IMPROVE study, which is the pivotal study for the SVS system that was a U.S. study overall. This was used for FDA submission and for approval for the aspiration valve system. This was a multi-center prospective randomized controlled trial. It was 2-to-1 treatment versus randomization. Both groups received optimal medical therapy. Pulmonary rehabilitation was required prior to enrollment, but not mandated throughout the follow-up period. The inclusion criteria are similar to other studies, but a little bit different in that the RV was greater than or equal to 150% of predicted, but the total lung capacity and the FEV1 are similar to other studies. And then the treatment group had, again, targeted lobe occlusion, lobar occlusion, but using the aspiration valve system. Next slide. So one of the unique features of this study was that to characterize the patient group for lobe selection was based on fissure integrity by using high-resolution CT scan analysis to measure whether fissure integrity was greater than 90%. And the treated lobe had greater than 40% emphysema, and the heterogeneity difference was 10% of difference between the ipsilateral targeted lobe compared to the non-targeted lobe, not including the middle lobe. One of the features that's different with this study is that the Hounsfield units was 920. The other studies that have been used with a Zephyr valve were 910. So although the degree of emphysema is lower, when you move to a higher Hounsfield units, your degree of emphysema is a little bit higher. So we're talking about really a 2 to 3% differences between these studies when you talk about using a higher Hounsfield units overall between 910 and 920. And then the CT analysis was done by a core lab using Vita diagnostic software. Next slide. So these are the endpoints. The primary safety endpoint was the incidence of thoracic serious adverse events through 6 months. The primary efficacy endpoint was the difference between the treatment and control groups and the mean change in FEV1 from baseline at 6 months to 6 months. And then secondary effectiveness endpoints are outlined as here, similar to what we talked about before. Responder analysis with 15% or greater improvement in FEV1, targeted lobe reduction measured at 6 months by QCT, reduction in hyperinflation by the ratio of RV to TLC, 6-minute St. George Respiratory Questionnaire for Quality of Life, breathlessness measured by a modified Medical Research Council, dyspnea score, and exercise capacity measured by a 6-minute walk distance. And that was only assessed at 6 months compared to baseline. Next slide, David. So this was the subject flow for the IMPROVE study. That you can see the 719 patients were consented, and similar to what we showed with the LIBERATE study, about 25% of those patients were enrolled, so almost a 4-to-1 screen to enrolled ratio. And then patients were randomized 2-to-1 to intervention with the SDS system compared to control. And then you can see that the good retention of subjects out to 6 months, which was the endpoint of the study. And then to look at durability of treatment response out to 12 months, you can see the numbers of patients that were reported on at 12 months. Next slide. Again, the patient group is mid-60s, severely obstructed, hyperinflated. RV was about 200% of predicted overall. The hyperinflation ratio was about 60% RV to TLC. SGRQ again was in the mid to high 60s. Patients had MMRCs that were 2 3/4. CAT scores were about 20, and distance walk was about 300 meters. The targeted lobe volume, which is shown here, is about 1.8 liters with emphysema severity in that targeted lobe above 60%, with a heterogeneity indices above 20% overall. Next slide. This is just a summary of the procedural data. So overall, the procedure took 20 minutes with a range of 99 to 73 minutes. The average number of valves used was just below 3.83 valves overall. And as you can see, about 70% had upper lobe treatment, or 80% had left-sided treatment overall. And about 9%, almost 10% of the patients had follow-up bronchoscopy, which was based on the investigator's discretion as well as the patient's desire to have valve adjustment if the goals of treatment were not assessed. Next slide. This is the primary effectiveness endpoint shown here. Is the change in FEV1 from baseline to 6 months in the intervention group with the SDS endobronchial valve, shown in the blue, compared to the gold, which is the standard of care. As you can see, about a 101 ml difference between the groups. And if you look at 12 months, that difference was about almost 100 mLs again. Next slide. This is looking at responder rates greater than or equal to 15%. Now, have you focus on the right side of the graph here. At 6 months, you can see that with the SDS system, about 36.8% of the group had a greater than or equal to 15% improvement in FEV1 compared to about 10% in the control group. This is the time of the primary endpoint of the study. But if you follow these patients out to a year, about 37% of the group had an improvement of FEV1 greater than or equal to 15% compared to 5% of the control. So the control group dropped off, and the treated group had durability of that treatment response overall and significant improvement in FEV1. Next slide. And this is just showing you in more of an illustrative way using the CT scan coronal images. This is a pre-treatment, as I mentioned before. Targeted lobe was 1.84 liters, and post-treatment it was about 0.87 liters, and this is a representative left upper lobe, the green lobe that was treated, so you can have about a 50% reduction in that lobe. If you look at the thing that we're trying to treat by using targeted lobe volume reduction and using a minimal important clinical difference of targeted low volume reduced by about 310 mLs, you can see that about 350 mLs, you can see that 75% of the group that had SVS treatment achieved that. You can see that almost 40% of the group had almost complete lobar atelectasis. About 50% of the group had about half the lobe that was reduced. So significant improvements in targeted lobe volume reduction was demonstrated in this study. Next slide. In hyperinflation indexes, it dropped by about 3.5% or 4% difference between the SDS treated group compared to control group. Next slide. And St. George Respiratory Questionnaire at 6 months, which was the endpoint of the study, was about a 13-point difference in improvement favoring the SVS treated group within the bronchial valve. And then at 1 year, there's approximately a 9.5-point difference favoring the SVS system compared to optimal standard of care. Next. And dyspnea also favorably improved, a 0.6 point reduction at 6 months, and at 12 months, a 0.8 point reduction. Next slide. In 6-minute walk distance, it was not statistically significantly different, although I showed you the REACH study that it was. And this just shows the variability of 6-minute walk distance in a group of patients with severe emphysema that has been shown in several trials. One of the factors could be is that the comorbidities patients have in terms of musculoskeletal problems, but also in several studies, including IMPROVE, the post-intervention rehab was not mandated, and that may have contributed to somewhat of a loss of training effect in patients post-randomization of treatment. Next slide. So this is looking again at short and long-term incidence of thoracic serious adverse events. As you can see in the first 0 to 6 months, the only thing that was statistically significant is shown is the pneumothorax requiring surgical intervention or prolonged air leak greater than 7 days. That was statistically significant, 12.4 versus 0. But the other parameters, although somewhat higher in the intervened group, such as the acute exacerbation of COPD. Remember, these are not sham control. These patients did not receive bronchoscopy here for control group in this study or the LIBERATE study. But pneumonia was higher, but not statistically significant in respiratory failure, et cetera. But if you look at in the long term, 6 to 12 months, you can see that the magnitude of these effects are less, and the other parameters such as pneumothorax or meeting this definition threshold are non-existent overall. Next slide. So again, pneumothorax for the first 12 months and improve. These are phenomenon that really happen in the first 72 hours after the treatment, as shown here from day of procedure versus day 3 in follow-up. These other episodes of pneumothoraces are related to interventions that are done with the adjustment period overall. So in most cases, if not all, the incidence of pneumothorax peaks around the peri-procedural period up to 72 to 96 hours. Next slide. This is the short and long-term mortality overall. You can see the treatment group shown here in the gray compared to control group shown in the gold. You can see that the treatment group, the short-term mortality is higher, but not statistically significant compared to control group from 0 to 6 months. The opposite is then true. From 6 to 12 months, the mortality is higher in the control group compared to the treatment group with SVS, but also is not statistically significant. You can see that the directional change occurs similar to what we discussed before that we saw in the surgical treatments in the NET trial. When you have effective volume reduction, you see significant benefits by treating the hyperinflation that we would expect. Next slide. And this is just a line diagram that shows that the thoracic serious adverse events decline in the blue group, which is the treated group, over time, and they are superimposable at 12 to 24 months compared with the control group, and hopefully the direction of this would continue to change over time, and that's what we hope to see in clinical practice. Next slide. So the conclusions for the IMPROVE study was twofold. One is that bronchoscopic treatment using the SCS system can provide statistically significant, but more importantly, clinically meaningful improvements in FEV1 and targeted lobar reduction that can do other important features of reducing dyspnea, improving quality of life with an acceptable and good safety profile. But this also showed that you could use an HRCT assessment to choose appropriate patients in the targeted lobe for effective bronchoscopic lobar reduction. Next slide. So I guess I just want to end up with a couple slides just putting this into context for you guys about, like, how do you implement this, how do you treat this, and what are the essential features? Well, first of all, which lobe do you treat? Well, the first important thing is pick one with little to no collateral ventilation. Fisher completeness greater than 90% in the case of using what I just showed you for the IMPROVE and the REACH trial, or using collateral ventilation being negative by using the Chartis system. Pick the lobe of higher destruction, at least 40% by using Hounsfield units of -920 or 50% using Hounsfield units of 910, and you prefer to treat the lobe of the greatest destruction. You also, if you have a homogeneous patient, you would like to treat the one that's less perfused, so you're targeting dead space. And what we use at Temple, we use a nuclear medicine SPECT CT, so we can look at perfusion that's based on the lobe anatomically, as opposed to just using the 3-6 quadrants that have been previously used overall. And because this is treating hyperinflation, you'd like to, if you have two lobes that you could target, you try to treat the one of the higher lobe volume, so you can have the greater treatment effect for the patient. And overall, although it's effective therapy for treating hyperinflation in patients with homogeneous disease, if you have greater heterogeneity, whatever treatment that you're looking at for lung reduction, whether it's surgical or a coil or a glue or a steam or a valve, you'll have greater treatment response if there's greater heterogeneity between the targeted treatment lobe versus the ipsilateral non-targeted lobe. Next slide. So this is just an example of this. Now, there's not a lot of data with using it bronchoscopically, but this is the data that we published from NET. There's a derivative manuscript overall. All the patients in NET, besides having CT quantitation done and qualitative inspection, they also had a perfusion scan done. And what this shows is you take all patients overall and you look at 1, 2, and 3-year outcomes and looking at a percent improved in FEV1. If you look at patients that were more oligemic by 20% with the resection of that lobe, you can see much greater magnitudes of improvement in patients with FEV1 or SGRQ or another index, San Diego Shortness of Breath questionnaire shown here on the bottom, as opposed to patients that were not oligemic shown here on the right. So picking patients' lobes for targeted treatment with the highest dead space should give you the greatest benefit for your patient. Next slide. And this just shows now what you're capable of looking at with, the overlay of nuclear medicine SPECT CT with a low energy or low dose CT scan that's done at the same time with perfusion scan that's done. You can basically target the less perfusion with the greatest volume, and this is an example of the right upper lobe in this patient had 4% perfusion but had 12% of the volume. Right middle lobe had 5% of the perfusion and 13% of the volume. So if you treated the right upper and right middle lobe of this patient, you could reduce the volume by 25%, but the perfusion was only 9% compared to treating the left upper lobe, which in this case was 12% perfusion, slightly higher, 12 compared to 9, and didn't have as much volume. So you try to pick the highest dead space when you can target a patient. But in practice, when you start doing this, you're going to want to have more than one lobe to treat in a patient if you can. Next slide. So one of the things that I didn't mention when I talked about the Liberate study, but I think it's important to know, is that we did an exploratory analysis and we put it in the paper that patients that were at greater risk to have respiratory failure that could result in demise in the Liberate study were patients that had treatment of the less diseased lobe when the contralateral less diseased lobe that wasn't treated was greater than 60% destruction. So what you should try to do is always favor treating the lung lobe that has the greatest destruction to try to avoid this complication. So it's not an absolute, it was a derivative sort of post hoc analysis that we did, but I think it gives you guidance to try to like pick what lobe to treat, or if you end up treating a patient like this, that patient's at higher risk for respiratory failure, you should be aware of that and take necessary precautions. Next slide. So I think one of the features that these studies have, there are different ways of predicting outcome in terms of EBV success and targeted volume reduction. Should you use Fisher integrity with HRCT, or should you use Chartis? How do you use, what to use? I think the Reach and Improve showed that you can have success with using HRCT to measure Fisher integrity to predict outcome. Believer and all these other studies that were Zephyr valve studies used the Chartis for these. And what's the value of either technique? Next slide. Well, to be quite honest, we don't know, but this is some way of trying to approach this. This was post hoc studies looking at retrospective analysis by Koester and colleagues that was published in Respiration a couple years ago, was looking at over 450 patients that were done in 4 registry trials, all done in Europe, that looked at patients that had Fisher integrity defined as complete if it was greater than 95% by using QCT with a qualitative inspection in addition to QCT, and then incomplete if it was less than 80%, and partially complete if it was between 80 to 95%. And some patients had Chartis results in these 4 studies overall. And the endpoint was the ability to predict a greater than 350 ml reduction of the targeted lobes that was treated. You can see the demographics are shown in the table down here. And what you can see here is the sensitivity and specificity of meeting this endpoint of a greater than 350 ml reduction in targeted lobe based on Fisher score cutoffs, as you can see. And you start to lose sensitivity as you go up to a higher Fisher integrity, but you become more specific. So it's a balance overall. And the gist of this paper, I encourage you to read that, is if your Fisher score is greater than 95% with using a 9-10 Hansford unit QCT parameter, that they had a good success, and Chartis didn't really add much to patients greater than 95%. If it was less than 80%, they showed that pretty much that Chartis didn't really identify any patients that had collateral ventilation negative status physiologically that you would end up treating. They found the greatest value of using it was between 80 to 95%. I can tell you I treated a patient today that had Fisher integrity on 9-10 Huntsville units that was 100% shown on the right. They had clear CV positive status by Chartis, and I went to the left side again with 100% Fisher integrity, and that was CV negative by Chartis. So I think we're going to learn more about the sensitivity and specificity of physiologic characterization versus QCT parameters in patients who have their QCT done during spontaneous breathing, and then we're assessing them under positive pressure ventilation under general anesthesia. So I think future data is going to help us determine really what the sensitivities and specificities of these 2 kind of measurement parameters to pick the lobe to treat as we go forward. Next slide. How about pneumothorax? But overall, like I told you, except for the REACH study, the incidence is about 26 to 27% in most studies I told you that most require a chest tube. There is the ex vacuo case that can occur in about 17% of the time. Most occur within 3 days after the intervention. Almost all occur in an ipsilateral non-treated lobe. I'd say in all cases, there was one case in Liberate that happened after a resuscitative measure, so we didn't know if it's the resuscitation or the endobronchial valve treatment. And most resolve, about 88%, without prolonged hospitalization or valve removal. Next slide. And I mentioned this before, the consequences are the same in terms of physiologic improvement. Next slide. But can we predict that? This is a post hoc analysis that was published last year in Respiration by Van Geffen. And what they did is they went back and they looked at pleural adhesions, both the number of them and the extent of the plaque overall. And as you can see down here in the bottom left, the number of pleural adhesions, it was higher in those that had a pneumothorax compared to no pneumothorax. And if you could come up with not only the number, but also the thickness of the plaque overall, and come up with a pleural adhesion score, that they had a little bit more robust fidelity. That you can see the sensitivity and specificity by doing ROC analysis is somewhat higher overall. So I think looking at your CAT scans and looking at how much pleural adhesions they are may be predictive when you plan your procedure, what lobe you choose, what side of chest you choose, or anticipate the likelihood of having a complication in pneumothorax, and whether a pneumothorax is more likely with this, with a pleural adhesion, to create a bronchopleural fistula if there's some tearing of the lung that would require a chest tube. Next slide. So other complications that have been reported are these: acute exacerbations, hemoptysis, pneumonia, respiratory failure, re-expansion, edema. We've reported that last year, but you'll see that in compressed ipsilateral lobes when you have effective volume reduction and the lobe expands overall. And it's just supportive therapy overall, diurese the patient, give them higher flow oxygen. It usually resolves within 24 hours. Airway kinking and effective bronchoscopic reduction with some torsion of a poorly compliant lung, overly compliant lung, can result in kinking, for which either valve removal or supportive care. And 2 weeks ago, as with Pavlov-Shaw, and Pavlov stented the lobe that wasn't treated with good outcome overall. And that might be an effective treatment overall. And I guess the last thing is the loss of effect over time. And there is some changes in the valves that can occur. Sometimes with effective treatment, there's some torquing of the valves. There's some reduction in edema of the valve, the orifice of the valve, so that you might have less effectiveness. And I think you need to have a high suspicion, and what we routinely do is a post-45-day treatment, HRCT, to look and make sure the valves are in appropriate position and we have appropriate volume loss. And if we don't, then we will do multiplanar reconstruction of the CT to see if we can identify any valve that may be malpositioned, and then we might reposition that over time. Next slide. So in summary, hopefully that you'll agree that we've done a lot. It took us 22 years, but we now have a bronchoscopic effective method for treating hyperinflation with using an endobronchial valve. The Zephyr and aspiration valve systems are representative of that. So we could have a clinically meaningful and durable reduction in expiratory lung volume that results in meaningful improvements in lung function and exercise tolerance and breathlessness and quality of life. Patient selection and lobe selection is key to maximize the improvement, both to reduce the volume, but do that in a way that you can target dead space, which is your key overall. And I think really if you want to maximize patient improvement and durability, it's reassessment of your valve placement, repeat bronchoscopy if needed, repeat HRCT assessment for patients if your clinical goals of lobar alexis are not met. And I think overall, as you start to develop your programs, you'll see that this is one feature that we treated. In the last 4 years, we've sent 80 patients to lung transplantation, and we're overall our lung volume reduction surgery program, which we are averaging 6 to 8 patients per year. We've doubled that in the last 6 months because you'll start to see lobes that you're not going to centrally treat because you're going to have pre-pleural distribution or emphysema, and those lobes are better treated with an external surgical approach to shave off the emphysema and preserve lung tissue. So that's it. Be happy to answer any questions at this time if people have them, or I can check this chat thing. David, if you want to moderate that.
Great. Thank you very much, Dr. Criner, for a very comprehensive discussion of basically where the data has taken us over the last few years. As Dr. Criner has mentioned, he will open up for questions at this time, so please type them into the chat box. While we're waiting for any questions to filter in, obviously I understand the hours are a little late for some of you folks on the East Coast, but thank you for sticking with us. Can I ask you this? Can you give us a little bit of perspective? You talked about the improvements in some of the outcomes with bronchoscopic interventions, also comparing it to MCIDs. How do these compare to other more traditional therapies that we may be more familiar with, be it bronchodilators or pulmonary rehab? How do these interventions compare in terms of absolute improvement or comparison to MCID?
Yeah, that's a good question, David. So we do have effective medical therapies. They're just not as potent in treating air trapping. High flow oxygen therapy by itself, you can reduce air trapping on magnitude of about 80 to 100 mLs. Rehab will give you about another 80 to 100 mLs. Dual LABA-LAMA therapy would, in some studies, give you about 280 and 300 mLs. So if you're seeing patients overall, like this patient group, you really want to maximize those medical therapies overall. And if you can do that with optimal medical therapy of improving their air trapping by 2 to 350 mLs, and then you can superimpose a 500 ml plus reduction, then you'll make a significant improvement in patients' outcome. It's important to maintain that therapy before and peri-procedural and post-treatment.
Great, thank you. We have a question from one of our participants. He's asking, of our patients with severe COPD, for the folks who are selected to be good candidates, what's the expected percentage who would be, you would expect to be good candidates for endobronchial interventions?
Very good question. So it depends on what the top of your funnel is. If it's your COPD patient population overall, you're talking about probably 15 to 20%. If you're talking about a more heavily screened population cared for by a pulmonologist and in by a referral pulmonologist, then it's going to be about 3 to 1 to 4 to 1 that you'll see will be an eligible patient.
Great. And a second question is, when we have patients who undergo lung volume reduction, how do we manage or how do we follow them for lung cancer screening, since obviously they are commonly going to be also high risk for malignancy?
Yeah, good question. So really be careful and not treat lobes that have a nodule that may be suspicious overall. So that's the first thing. Never take the chance that you're going to treat a lobe that you can't radiographically assess over time. And, I would favor in this patient group overall to stop smoking, but they're at high risk overall. I would continue to use the regular NSLT sort of follow-up periods of time for this patient group and have a high index of suspicion. I haven't personally had one yet, but I know of people overseas that have had about half dozen patients that have developed lung cancer over time after successful lung reduction treatment. And basically it's just having a high index of suspicion if a patient has hemoptysis or radiographic changes overall. There are a change in what they've had historically.
Great. And I guess we'll finish the hour with this last question. It's a question with regards to credentialing and how we as a society should be restricting or practicing, I guess. But what are your insights with regards to how we should limit who performs this procedure, or perhaps which institutions perform this procedure, and then also any insight into credentialing requirements for hospitals?
Yeah, it's a very good question. So I think there has been there has been due diligence and conscientiousness placed by the industry that's developed these technologies to do controlled dispersion, not to just basically have everyone who can do bronchoscopy take these and start doing them, to set up training courses or training format where physicians can come and be trained how to use this at centers to do this and how to select the candidates, how to do multidisciplinary care plan for these patients, and be educated on lobe selection and device, not only for the procedure, but how to manage the patients post-treatment wise. So I think that's one thing. I think the second thing is that this is a pretty small community overall, and I think the majority of us are committed to help others do this successfully and safely to improve the outcomes of patients, because this is the beginning, I think, of other forms of interventional bronchoscopic procedures with treatment potential that can have truly meaningful outcomes for our patients. So I think all of us want the field to succeed, and I think it's going to take a lot of collaboration for us to discuss and talk amongst us together. The procedure is easy. The selection and the post-procedural management is what's key. And I think that's what we as a group have to bind together to really kind of like maximize clinical improvement.
Great. Thank you again, Dr. Criner. Because of the lateness of the hour, I apologize to the individuals whose questions we weren't able to get to. On your screen, you should see the upcoming webinar series and the tentative schedule upcoming. And again, thank you everyone for joining us. Thank you again to Dr. Criner for joining us and lending us his expertise and dealing with our technical issues with the skipping and dancing slides. So thank you everyone, and have a wonderful evening.
All right.